expert on any of these conditions, but we're going to talk about a bunch of genetic conditions today and what they mean. We have some respiratory ones, and then we've got, let's see, some seizure disorders, kidney disorders, metabolic, I'm missing some, lots of conditions. So yeah, let's get started with these. We will get started with one that you maybe have heard of, and it is cystic fibrosis. This one I actually know relatively well because tomorrow I have to do a simulated genetic counseling case for a cystic fibrosis patient, so I've prepared some for that. But cystic fibrosis is autosomal recessive, so we know that that means you have to inherit 2 copies of a mutation, one from each of your parents, in order to have the disease. And the specific gene that is mutated in cystic fibrosis is called CFTR. This is the cystic fibrosis transmembrane regulator protein, something like that. It basically codes for a protein that is supposed to be on your cell membranes that regulates the movement of chloride ions, so like salts and water, in and out of your cells. And so in most people that have a functioning CFTR protein, those ions and water are able to move freely, and it makes the mucus in your body very thin and watery, and it can be cleared out and flushed out of your system. But because people with cystic fibrosis are either lacking that protein or the protein is not working as properly, that transfer can't happen as well, and it leads to mucus that is really thick and sticky, and it can build up in places like the lungs and the digestive tract, the pancreas, places like that. So that leads to a lot of the symptoms. And the most common mutation is called F508del, or delta F508. And this is a specific deletion of a nucleotide, or of a amino acid in the protein. And that means that the CFTR protein is produced, but it is not properly produced, and it's not exported to the cell membrane. So it can't work properly, but it is made. And so we'll talk about that, because that's like a way that it can be treated, is because the protein is made. But that's the most common mutation. There are other types that lead to like no protein at all, or whatever. But that thick mucus can lead to chronic cough and wheezing, shortness of breath, obstructive lung disease. Pancreatic insufficiency is a big thing with cystic fibrosis because of the buildup of mucus in the pancreas. The pancreas can't release pancreatic enzymes, and pancreatic enzymes are what help digest your food. So people with cystic fibrosis, especially like infants, they will eat and eat and eat and eat and eat, and they'll lose weight. Like, they can't keep on weight because they're not digesting their food. It just like goes right through them. So people generally have to take pancreatic enzymes with all of the food that they eat. There's a risk of diabetes. There's risks of like psychiatric symptoms like anxiety, depression. And then a big thing is that the vast majority of males with cystic fibrosis are infertile. And this is because in the womb, like before they are born, that thick, sticky mucus actually builds up in the vas deferens, which are the tubes that carry sperm so they like don't even have vas deferens. They're born with a vasectomy, essentially. So they do still produce sperm, and they could have a baby with like IVF, but typically they're infertile. But females are typically fertile. So generally a condition with a low life expectancy, but recently there are a lot of treatments that are available, especially for that most common mutation. So there's a medication called Trikafta, and it essentially causes that protein to go up to the cell membrane and work properly. So it's kind of like a cure. It doesn't cure the genetic cause, but it kind of cures the symptoms, a lot of the symptoms of cystic fibrosis. So Trikafta is a very effective treatment. Alright, our other lung disease is called alpha-1 antitrypsin deficiency. This is more of an adult onset one. Cystic fibrosis is like, you would know when the baby's born usually. But alpha-1 antitrypsin, so it's caused by mutations in the SERPIN-A1 gene that makes alpha-1 antitrypsin. It's a protein, and one big function of alpha-1 antitrypsin is that in the lungs it binds to neutrophil elastase, which is an enzyme that you do need, but you want alpha-1 antitrypsin to bind to it in the lungs because it protects the elastin in your lungs. So if you're not producing alpha-1 antitrypsin properly, it leads to lung damage, and there's a very high risk of COPD and chronic bronchitis, severe asthma, shortness of breath, things like that. If you do happen to have a mutation that leads to production of an abnormal alpha-1 antitrypsin, rather than like none of it, the abnormal protein like aggregates together. It forms clumps in the liver, and so those mutations are associated with liver damage as well. But there are some mutations that lead to like no alpha-1 antitrypsin, and so it's not accumulating in the liver because you don't even have it. But yeah, that is a more adult onset, and there are treatments for that one as well to like replace the alpha-1 antitrypsin. Next, oh yeah, we do have disorders of sexual development. So we have this crazy long name, Mayer-Rokitansky-Kuster-Hauser syndrome, which I think people just know as MRKH syndrome. And this one, we actually don't really know if it's genetic. Like, we don't know the genetic cause that is, but it leads to the absence of a uterus, and like parts of the vagina. So women, it only affects people with XX chromosomes, biological sex females, and they do not have a uterus or parts of the vagina, so they cannot have kids naturally. Type 1, that's all it causes, but type 2 can also affect the kidney. It can have heart defects, and then some like skeletal abnormalities and sometimes hearing loss. But type 1 is just congenital absence of the uterus, which is interesting. deficiency. The condition is usually known as congenital adrenal hyperplasia. And this one is caused by mutations in CYP21A. It's autosomal recessive, and it affects your adrenal glands, which are on your kidneys, and they produce hormones. And so people with this, they don't produce enough cortisol or enough aldosterone. Aldosterone is important for regulating the salt in your body, like the salt concentrations. And they produce too much androgen. Androgens are male hormones, hormones that drive male development. So both males and females can have this condition, but for people that are biologically born females, they may have more male type genitalia and sexual characteristics. Sometimes it's called ambiguous genitalia when they're born, that it's hard to tell if it's male or female. Whereas males, like, because they have too much male hormone, it doesn't really affect them when they're babies. Like, they're still gonna look like boys. But in, like, childhood, generally they'll have very, very early puberty, like deep voice, acne, facial hair, like very early on, because they're producing so much extra of the androgens, the male fertility hormones. So yeah, it's called virilization when you have like male sex characteristics, or like pronounced male sex characteristics. There is some of them, like, don't cause anything life-threatening like other symptoms, but the salt wasting form, I mentioned that aldosterone regulates your salt, and so if you have the salt wasting form, you don't produce enough aldosterone, and salt, you can't like regulate the salt in your body, and you lose a lot of salt through your urine. So that can lead to like vomiting, metabolic acidosis, dehydration, life-threatening symptoms, usually in infancy. So that would be important to look out for. Alright, I think we have like one more sexual development one that I'm going to do. Let's see. Let's do Swire syndrome. Swire syndrome. This is another sexual development one, but kind of the opposite in a way. So in this one, there are autosomal dominant mutations. They can be in many genes. One of them is the SRY gene, which I guess this would not be autosomal dominant. It would be Y-linked. But so you may know that males have an XY chromosome, females have XX. I give the disclaimer every time that when I say this, I'm talking about sex, like biological sex. It doesn't have to do with how you identify male and female. I'm just talking about the chromosomes. But so the Y chromosome is what essentially makes you a male. It's what causes you to develop into male. And the SRY gene is the specific gene on the Y chromosome that makes that happen. The SRY gene is what females don't have, and it's what causes you to develop into a male. People with this condition have XY chromosomes, so male chromosomes, but they may have a mutation of their SRY gene. So even though they have a Y chromosome, if external genitalia. They have fallopian tubes. They have a uterus. Very typical, like, female genitalia. Typically the gonads, the ovaries or testes, are what is abnormal, so they will typically have what's called streak gonads, which are like, they're neither ovaries or testicles, they're just like scar tissue that isn't really functional. So typically they're infertile and don't have periods or anything, but I think a lot of them identify as female, I'm not sure, but yeah, female characteristics with XY chromosomes, so that's definitely an exception to, you know, XY makes you male, like, not necessarily. So sometimes I wish politicians had to take science classes, is all I will say. Okay. The next one we will talk about, let's see, alright. We will talk about one called RCAD, which is renal cysts and diabetes. Super creative name for that. And I bet you cannot guess what it causes. Renal cysts, right? Okay. Which is kidney cysts, kidney disease. Sometimes they will have structural renal anomalies, so like one kidney not even forming, horseshoe kidney, which is where your kidneys are essentially connected. It's like one kidney that looks like a horseshoe. And then they will have early onset type 2 diabetes. So type 2 diabetes at like a way earlier age than you would normally see it. They can also have MRKH, which is the no uterus. And this is autosomal dominant, so only need one copy. Typically it's caused by mutations in HNF1B, but HNF1B is on the 17th chromosome, and there are some people that have a deletion of that part of the chromosome at 17q12. And if you have the deletion there, you have this condition because you're missing that gene, so it's like having a mutation. But people with that deletion might also have, especially like psychiatric symptoms, like intellectual disability, an autism diagnosis, schizophrenia, anxiety, things like that. If you happen to have the deletion of that chromosome. Next is autosomal dominant polycystic kidney disease, otherwise known as ADPKD. And it's a lot like what it sounds like. So it is caused by mutations in PKD1 or PKD2. I love when the genes are exactly what they are. Like, polycystic kidney disease is caused by polycystic kidney disease 1 and polycystic kidney disease 2. Love it. But it leads to kidney cysts, a lot of kidney cysts in both kidneys typically, and pain that goes along with that. These people can also have pancreatic and liver cysts. They have a risk of intracranial aneurysms, so in the brain. There's also a risk of heart disease and polycystic liver disease, which is more so in females with the disease. So a lot of cysts in these people. I think typically, like, it doesn't present until adulthood. There is an autosomal recessive form, and in general, stuff that's recessive is more severe and more like childhood onset. So that leads to like cysts in infancy and can be fatal in like the neonatal autosomal dominant is typically more adult onset. Okay, next is tuberous sclerosis. I don't know if I talked about this in the last video. I know I had to know it for the last exam. I don't know if I talked about it. Once again, TSC1 and TSC2 are the genes. Love that. It is autosomal dominant, so you only need one mutation. However, 2/3 of cases are de novo, meaning that they just happen. Like, you still only need one mutation, but it happens, like, in the germline. You didn't inherit it from a parent. An interesting thing, the reason I included both of these syndromes is because there's actually TSC2 is really close to PKD1 on the same chromosome, and so there are people that have a deletion that includes both of those genes, and so they have autosomal dominant polycystic kidney disease and tuberous sclerosis. But tuberous sclerosis, it impacts the brain a lot, so a lot of people will have seizures, sometimes intellectual disability, or tumors in the brain, like astrocytomas, subependymal tumors. They typically have a lot of skin findings, so something called Sjogren patches. I couldn't even find an explanation of it, only pictures, so you'd have to look up a picture if you want to see it. Angiofibromas on the face, which are like small little growths. Periungual fibromas are little, like, tumor things that are around or underneath the fingernails. They can have kidney cysts and kidney disease, tumors of the liver or kidneys, benign tumors of the heart, and then there's a specific lung disease that is the longest word I've ever seen, lymphangioliomyomatosis. That happens more so in women that have tuberous sclerosis. Alright, let's see how we're doing on time. Alright, which one do we want to do next? Okay, let's do von Hippel-Lindow syndrome. This is more so one that I need to know for my cancer class, but they did mention it in pediatrics, but some of these are like cancer ones. So von Hippel-Lindau, another good one caused by the VHL gene, and this one causes hemangioblastomas, which are like tumors of blood vessels, I believe, and they can happen in the brain, spinal cord, and the retina, and if they happen in the retina, then it can be associated with vision loss, kidney cysts, and a really high risk of renal cell carcinoma, which is kidney cancer. So up to 70% risk, and that's the leading cause of death for people with von Hippel-Lindau. Pheochromocytomas and paragangliomas are not cancer, but they are tumors that, where do they, I think they can be on the adrenal glands and elsewhere, somewhere else, like in the head and neck, I don't know, they're like endocrine tumors, pancreatic cysts and pancreatic neuroendocrine tumors, and then endolymphatic sac tumors that can lead to hearing loss. So hearing exams like a lot, so it's definitely a time-consuming thing to have to do, which is true for a lot of the cancer syndromes. Another one I'll quickly mention is Bert Dubet. One reason I'm mentioning this is that someone in the comments of my last video said they actually have it, so I wanted to mention it. But it is caused by mutations in FLCN. It also causes kidney cysts. It also causes renal cell carcinoma. But von Hippel-Lindow is associated with a type called clear cell, whereas Bert-Hogg-Dubé is associated with a type that is a hybrid of oncocytoma and chromophobe cell types. They can have fibrofolliculomas, which are like little growths on the skin, epidermal cysts, collagenomas. I don't actually know what that is. I think it's a skin thing. Cysts in the lungs are very common, and then it's also possible to have a pneumothorax or a collapsed lung with Bert-Hogg-Dubé. Okay, next one. This little note card ring is not being so kind to me. The other cancer one is Vancomycin Anemia. This is one I don't have to know for my pediatric class, just my cancer class, but I thought it was interesting, so I put it in this set of note cards to tell you about. So this one is autosomal recessive. It can be caused by a lot of different genes, but interestingly, you've probably heard of the BRCA genes, maybe not. BRCA1 and BRCA2 BRCA are genes that, if you have a mutation in them, they predispose you to certain types of cancer. You might have heard of Angelina Jolie having a BRCA mutation, and she got her breasts and ovaries removed because it's associated with breast and ovarian cancer. So BRCA, those people have one mutation, autosomal dominant. Fanconi anemia can happen if you have two people that have a BRCA mutation and they both pass it on to their child. So autosomal recessive BRCA mutation. So that's like an interesting counseling consideration. If you're seeing someone for BRCA, it's like we want to make sure your partner doesn't also have BRCA because could get Fanconi anemia. But it's also caused by other genes. Like there are specific Fanconi anemia genes, but Fanconi anemia is a childhood condition. They have pancytopenia, which is, so anemia is the lack of red blood cells, like you make too few red blood cells, and then like thrombocytopenia is the lack of platelets. They're lacking red blood cells, white blood cells, and platelets, so really bad anemia. Bone marrow failure. Generally they're very short to have growth delays. They can have differences in skin pigmentation, microcephaly or a small head. Their thumbs are often different, so they could have an absent thumb, a thumb that didn't develop properly, or a bifid thumb, which is like kind of like two thumbs. So a bifid thumb. They can have other skeletal and heart neurological anomalies, and then there is a high risk of blood hematological malignancies like acute myeloid leukemia. There's also a chance of other tumors like neuroblastoma, Wilms tumor, which is a kidney cancer, primitive neuroectodermal tumors, skin cancers, a lot of cancer risks. Okay, next we are moving on to some of our muscular and neurological conditions. Neurological, I guess. And the first one is, again, probably one you've heard of, which is best known as ALS, or Lou Gehrig's disease, but ALS stands for amyotrophic lateral sclerosis. Maybe you've heard of it. And ALS, it is not always genetic. Well, it probably is always, like, due to some sort of genetic cause. It's just that we don't know all of the genetic causes. So, like, it's only a smaller percentage of cases that we can actually do genetic testing and find, like, this caused it. So only about 10% of cases are familial, where, like, mom has it, child gets it, you know, like, it's passed on. 90% are sporadic, so they just happen. And of those ones that are sporadic, about 15% will have a genetic cause that can be identified. So, long story short, not a ton of genetic causes that we know. Like, well, there are a ton, but a lot of people have ALS without a known genetic cause. But the most common one is C9orf72. That is the most common gene. 7% of the sporadic cases and 40% of the familial cases are caused by that gene. And it is particularly a repeat expansion disorder. So I think we talked about this last time, but it's basically a lot of conditions are caused by mutations in a gene. So, like, the sequence is changed. I kind of like to think of this as, like, you have a recipe and you changed an ingredient, or you took out an ingredient. Like, that changes the recipe, it changes the final product. Repeat expansion are where there's sections in your genome that are like GGG, GGC, 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 like a repeated 3 or 4 or 5 or 6 nucleotides. And in repeat expansion disorders, you have too many of those repeats. So kind of like adding 3 cups of milk instead of 1 cup of milk. Like, you're not changing the ingredient, you're not changing the milk, you're not taking it out, but you're, like, adding way too much, and you're gonna get, you know. So it's not a perfect explanation, but I think it helps. So yeah, that particular gene, it's repeats that lead to that. But this condition leads to particularly the loss of both upper and motor neurons. So you lose a lot of abilities, a lot of muscular abilities. So progressive paralysis of different parts of your body. Things like that, foot drop, like paralysis of the feet, the legs, the arms, the hands. And then it typically progresses, well, it can start with, like, swallowing and breathing difficulties, but oftentimes it's the, like, limbs first, and then it progresses to, like, the diaphragm and swallowing muscles, and that's typically how people pass away of ALS. Is like they can't swallow anymore, or they can't take care of themselves anymore. There are a couple treatments available, but it's like specifically for certain genes, and not many people have each gene associated with it, so it's kind of hard to come up with treatments specific to that. Okay, next we will do congenital myasthenic syndrome. I don't know if you guys have heard of Myasthenia Gravis. If you're not in the US, maybe not, but we hear drug commercials all the freaking time about myasthenia gravis. Myasthenia gravis has a very similar presentation, but it is autoimmune, so it's not like an inherited genetic condition. This has a similar presentation, but it's not autoimmune. It can be autosomal dominant or autosomal recessive. And they are disorders of the neuromuscular junction that lead to muscle weakness, particularly that worsens with exertion. So like you get weaker when you exert your energy or your muscles, and it primarily affects the muscles of the eyes, the limbs, and the bulbar muscles, which are like your swallowing throat muscles. And the onset of this one is usually in childhood, whereas I think myasthenia gravis is usually not, usually in adulthood. Okay, the next one is Huntington Disease. Maybe you've heard of this one as well. And this one is another of those repeat expansion disorders. So having too many repeats, specifically CAG repeats in the HTT gene. CAG. So normal is having 26 or less repeats. Intermediate is 27 to 35. Reduced penetrance is 36 to 39. That means if we find that someone has 36 to 39 repeats in the gene, they may or may not develop Huntington's. We don't know. And then greater than 40, you definitely will develop Huntington's. And also important is that Huntington's shows expansion, repeat expansion. So this is essentially where like your father has 25 repeats and you get 30 repeats, and then your child gets 40 repeats. So the repeats expand with successive generations. And so that is one way that, like, if your parent has 30 repeats, they're not going to get Huntington's, but you could potentially get 40 repeats and have Huntington's. And then the number of repeats correlates with the severity of the disease. So, like, if your parent had 40 and had the disease, and they got the disease at, like, age 60, and then you get more repeats, you're probably going to show the disease earlier than your parent did. And it is associated with kind of involuntary movements called chorea. It's associated with balance and speech and swallowing problems, trouble organizing and completing tasks, trouble with memory, so a lot of very dementia-like symptoms, psychosis, depression, anxiety, OCD, so a lot of psychiatric symptoms like dementia, as well as involuntary movements, twitching, things like that. It is possible to happen in children, like I said, if there are greater than 60 repeats, so more repeats, generally the earlier that you're going to show the disease, so yeah. And it's autosomal dominant. I'm not sure if I said that, so if a parent has it, there's a 50% chance that they would pass it on to their child. I'll mention this one because you've probably heard of it. Parkinson Disease. Parkinson's is not super genetic. I think them Parkinson's. It just means we can identify something that put them at a higher risk or could put you at a higher risk. So it's not like a gene disease thing. But there are some genes that are associated with it, especially if you have early onset Parkinson's, so before the age of 50, then it's much more likely to be like something genetic if it happened that early. But the symptoms are tremor at rest, so you can have intention tremor, which is like where you go to do something and you shake, but people with Parkinson's have tremors at rest, so like they're just sitting there and their hands are shaking, or they're shaking. They can have a slowness of movement, so like trouble making movements, limb stiffness and rigidity, gait and balance issues are some of the most common symptoms. Okay. Next is one that I know pretty well, Alzheimer's disease. I have studied this one a lot, and my grandma had Alzheimer's, so fairly familiar with it. Like Parkinson's, there really is no gene that like is the Alzheimer's gene, like makes you 100% get it. There's a plane going by. Sorry. So it's mostly multifactorial. I mean, 10% of people out there will get Alzheimer's, so yeah, it's caused by many things, lifestyle, genes, etc. But if you have early onset Alzheimer's, so before the age of 65, it's definitely more likely to be genetic. Mutations in the APP gene are a possible cause, as well as PSEN1 and PSEN2 are genes that are associated with early onset. So Alzheimer's is caused by an accumulation of amyloid plaques in the brain. So it's a protein called amyloid beta, and it aggregates together, clumps up together, and forms these plaques in your brain. And APP is the amyloid precursor protein. So it's a protein that is a precursor to amyloid beta. So if you have mutations in it that make it produce more amyloid beta, you're more at risk of Alzheimer's, especially early onset. And something interesting is that APP is located on the 21st chromosome, and people with Down syndrome have 3 of the 21st chromosome, so 3 copies of APP, and so they produce more amyloid beta, and so pretty much everyone with Alzheimer's will get, pretty much everyone with Down syndrome will get Alzheimer's, typically at like before age 50 or 60. Yeah. But there are other like moderate risk genes that are associated with late onset. But you're probably familiar with a lot of these symptoms, like confusion, poor judgment, issues with language, memory, vision, smell. They can have agitation, hallucinations, things like that. Typically like a complete loss of memory by the end, which is pretty much what happened to my grandma. So there are other kinds of dementia. I won't really go through them, but Alzheimer's is the most common, but you do have dementia with Lewy bodies, as well as frontotemporal dementia. deficiency of a particular enzyme that breaks something down in your body, whether that's a component of proteins, a component of fats, or carbohydrates. It's a deficiency of an enzyme that breaks that down. So essentially leads to symptoms if you eat a certain thing, or have too much of a certain thing in your body. Is kind of a broad umbrella of metabolic. So specifically for phenylketonuria, this is autosomal recessive mutations in PAH, which is the phenylalanine hydroxylase. So an enzyme that breaks down phenylalanine, which is an amino acid that's part of proteins. It's one of the basic amino acids in your body. So these people have really, really high levels of phenylalanine if they eat protein, because the body can't break it down properly. So it's diagnosed by really high levels of phenylalanine, and if it's not treated, if you try to eat like a normal diet, then symptoms include behavior issues, microcephaly, so small head, seizures, intellectual disability, and the other interesting symptom is hypopigmentation, so like really light skin and hair, and this is because phenylalanine is broken down into tyrosine, a different amino acid, and tyrosine is a precursor of melanin, which is like what makes your skin and eye and hair color. So if they can't break down phenylalanine, they can't make tyrosine, and they don't make enough melanin. So people with it, untreated, typically have very light skin, or my professor even said that there was an Asian girl who had blonde hair, and once she was treated, she had like black hair again, but she had blonde because her body couldn't make melanin. So this is treated with a very low protein diet. They really can't eat phenylalanine and it's in all proteins, because they can't break it down. So they eat hardly any protein, but they will eat specific formulas that are made for them that have like all of the other amino acids that they need, and especially tyrosine to supplement. And so they get all the amino acids that they need, but no extra phenylalanine. Yeah. Alright, next one we will do, let's do maple syrup urine disease. You heard that correctly. Maple syrup urine disease. So this one is, again, autosomal recessive. Literally all of the metabolic ones are. And this one, I believe it's a disorder of organic acid breakdown. And it leads to elevated levels of leucine, which is an amino acid, and that is the main one that is like neurotoxic, so toxic to the brain and the neurons. And people with it will have like progressive encephalopathy, which is like brain disease, issues with brain and like motor symptoms, if they're not treated. I also have an increase in valine and isoleucine amino acids, and the presence of allo-isoleucine, which I don't believe is present if you don't have this disease. So it's like very characteristic of this disease. Without treatment, they can have vomiting, developmental delay, neurological issues, some issues with movement like ataxia, and then the very characteristic thing is that their urine smells very strongly of maple is like where these reactions are taking place, and so if you just give them a new liver, they're fine. Their liver does it normally. So, yeah. But yeah, strong smell of maple syrup, of the urine. Okay, let's see. Alright, next we will do galactosemia, and wow, okay, having some issues. Galactosemia. So we did some of the protein disorders. This one is a carbohydrate disorder. So for galactosemia, most of the time it's caused by mutations in GALT, G-A-L-T, which I think is the galactose transferase. And so they cannot break down galactose, and it leads to excess galactose in the body. And that can lead to liver failure, kidney failure, cataracts, sepsis, developmental delays, speech problems, yeah, stuff like that. And so people with this, they have to eat no lactose, so they are not even allowed to breastfeed as infants. No breastfeeding, no formula. They have to have soy formula. Nothing with lactose or galactose in it, which is, I imagine, really difficult. Because it's not even just like dairy free, but like anything that contains any galactose sugars. So yeah, treated with a lactose-free diet, and this is one where even with treatment, they're still at risk for some symptoms. So people, even with treatment, can still have speech issues and problems with fertility. A lot of the other metabolic syndromes, if they just adhere to their treatment, they should be fine. That's one where they can have some residual symptoms. Okay. Next, we will do hereditary fructose intolerance. Bogus. Hereditary fructose intolerance, so another carbohydrate one, sugar one. So this is a deficiency in the aldolase B enzyme. I'm gonna have to look up what that actually does, because I guess I didn't write it down. But if they eat fructose or sucrose, which is basically sugar, they can have nausea and vomiting, abdominal pain, hypoglycemia, failure to thrive, liver dysfunction, hepatosplenomegaly, which is enlarged liver and spleen, renal tubular dysfunction, and interestingly, they typically have an aversion to sweets, so they have to be treated with a low fructose and sucrose diet, so like very, very low in sugars. But typically they're like very averse to sweets, and they can taste sugar if it's in anything, and they're like, ew, I don't want sugar. So kind of an interesting one, because I think for a lot of the other conditions, like, it's very, very hard to stick to your diet because you want the proteins and the fats, glucosidase. And this one leads to, well, it can have an infantile presentation, a juvenile, and an adult. So depends on when it presents, but the infantile can be very severe with profound hypotonia or low muscle tone, an enlarged heart, hypertrophic cardiomyopathy, hearing loss, loss of reflexes, and it's usually fatal by age 1 or 2 if they don't have proper treatment. And then the juvenile and adult forms are less severe but are still severe conditions, and this is a glycogen storage disorder, so it has to do with something in the glycogen storage pathway, but I'm gonna have to look up exactly what. And it can be treated with enzyme therapy, so it is actually treatable, and I think people, even with the infantile, can survive if they have the proper enzyme therapy. Let's see. I did that one in the last video, I think. A couple of these I'm like, wow, never seen that before in my life. Which is not good since I have an exam. But I don't want to do ones that I feel like I've never seen before in my life because I'm framing this as like a teaching you video. Okay. Next, we're going to talk about the mucopolysaccharidoses disorders. Long words. So these are all disorders. They're lysosomal storage disorders, and they are, again, mutations in enzymes that break down something called glycosaminoglycans, also known as GAGs. And so if they're missing a particular enzyme, it builds up these GAGs in particular organs and leads to symptoms. So there are 6 of these that have some very similar symptoms. So I'll talk about like the symptoms of the first one and then just sort of mention the other ones, because they do have similar-ish symptoms, just different enzymes. So the first one is Hurler syndrome / Shea syndrome. So it's actually depending on the like severity of it. It can be Hurler syndrome, Hurler Shea, or Shea, depending on the severity. But this one can lead to, well, a lot of them can lead to macrocephaly and hydrocephalus, so too much fluid on the brain, hepatosplenomegaly, enlarged liver and spleen. A big thing with mucopolysaccharidoses is coarse facial features, known as coarse facial features. So typically they will have like very thick, bushy eyebrows. I don't know, like the other things that are described as coarse, like full cheeks. If you look up someone with a mucopolysaccharidoses, you'll see what they're talking about with the coarse facial features. A hoarse voice is common, like a deep hoarse voice. Clouding of the corneas, contractures of the muscles, so like contractures that you can't like straighten your arm, skeletal issues, cognitive impairment, carpal tunnel syndrome, stuff like that. And this one is treated with an enzyme replacement therapy, or what is SCT? Wait, I don't remember what SCT is. It says treated with SCT. also says that there's an enzyme replacement therapy. I need to look up what SCD is. But yeah, and so then we have Hunter syndrome or mucopolysaccharidosis type 2. And this one is similar. Rounded cheeks, full lips, broad nose are kind of those coarse facial features. This one's later onset and it's X-linked, so it primarily affects boys. Sanfilippo syndrome or type 3. This one it has a lot more like behavioral problems and developmental regression. So this one is actually, I don't think there's a treatment for it. And it's known as childhood dementia. So like they typically develop normally for a few years and then they will start regressing and like losing abilities and skills. And it is fatal. I'm not sure about the life expectancy of the others, but I know that Sanfilippo, especially for the most severe type, the life expectancy is like in the teenage years. We have Morquio syndrome or type 4. This one has more skeletal anomalies, so they can have like really severe knee, wrist, hip, rib anomalies, and they typically have normal intelligence, and that one is treated with enzyme therapy. I don't even know how you say this one. Maratolami type 6. This one pretty similar, but they can have cardiac conditions. Most of the other stuff is the same. And then Sly syndrome type 7 is, I think this one can be fatal. It's the rarest one, and I think it can be fatal. Progressive intellectual disability, risk of infections, and most of the other symptoms of the other types as well. So those are the 6 types of mucopolysaccharidoses. Let's see. Okay, I think this will be our last condition, because it's my last note card, and then we have cystic fibrosis again. So this one is Tay-Sachs disease. Focus. You can see it. You can see it, right? Tay-Sachs disease is mutations in hexosaminidase A. Hexosaminidase A. And it can be, again, infantile, juvenile, or chronic and adult onset. It leads to deterioration of the mental and physical abilities, blindness, deafness, dementia, seizures, these characteristic cherry red spots in the eye, and then an increased startle reflex. And unfortunately for Tay-Sachs, there's not any real treatment. The treatment for it is supportive, so it's like palliative care, helping with symptoms. And if it is infantile, then it's usually fatal by about age 5. One interesting thing with this is that there is a founder mutation in the Ashkenazi Jewish population, so there is a much higher risk of Tay-Sachs in Ashkenazi Jewish people with that ancestry. So yeah, that goes for actually a lot of conditions. Tay-Sachs, BRCA 1 and 2, fibrosis is slightly elevated. Some other ones that are more common in Ashkenazi Jewish people. But yeah, sorry to end on a low note. We ended with a condition that's not very good. Not that any of these are good, but yeah. I hope you enjoyed my study session today. I really hope you learned something today. Sorry for any background noise. I know there was like yard work and planes and stuff. But yeah, I hope you guys enjoyed this video. Let me know if you learned something, and I do love to see your guys' like saying, oh my gosh, like I had this condition, or I know someone with this condition, and sharing your personal experience. I really like to see that. So yeah, but yeah, thank you. Wish me luck on my last exam, and we'll be back with more genetics videos and other types of videos soon. So sleep well, everybody, and